Lisfranc and midfoot injuries. These dislocations are best seen with weight-bearing X-rays. 25 February 2023. This video has been produced from the book source. I would like to thank chapter, book editor and author Amol Saxena. Citation: International Advances in Foot and Ankle Surgery. Springer, London, 2016. Injuries to the Lisfrances, tarso-metatarsal, and midfoot, show-parts and naviculo-cuneiform joints are being more recognized with sports injuries. Historically, these injuries occurred with higher energy trauma such as equestrian accidents and motor vehicle accidents. Overt traumatic loading and plantar flexion of the forefoot can cause fracture dislocation of the midfoot, but often subtle sprains and diastasis may not be noted unless weight-bearing films and other diagnostics such as computed tomography, CT, and magnetic resonance imaging, MRI, scans are performed. Soccer players and dancers are among the most vulnerable in sports. Figure. Other sports where the forefoot is fixed such as windsurfing and when patients get the foot stepped on, i.e., football, baseball and basketball, are also commonly associated with these injuries. Anatomy, biomechanics, and evaluation. Axial loading of the metatarsals can cause fracture and diastasis or dislocation, particularly in regards to the second metatarsal base and medial cuneiform. Normally the second metatarsal base is the keystone to the midfoot arch in the frontal plane and should be the high point. The relationship of each metatarsal to their respective tarsal bone they articulate with is critical, as is the distance between the second metatarsal and the first, medial, cuneiform. After midfoot injury, weight-bearing and oblique radiographs should show offset, malalignment, of no more than 1 mm with the metatarsals to their respective tarsals. Ideally, though, the region of the main Lisfrances ligaments, spanning between the second metatarsal and the first cuneiform, can have an acceptable difference to the asymptomatic foot of 2 mm. These dislocations are best seen with weight-bearing X-rays. A fleck sign is often seen with the Lisfrances ligament avulsion. Figure. CT, MRI may be warranted. Nunley and Vertalo described a classification system where Stage 1 was a sprain with no diastasis and is treated non-surgically, Stage 2 diastasis of 2 to 5 mm with no loss of arch height, while Stage 3 exhibits loss of arch height along with abnormal diastasis, both of which are treated surgically. Clinical presentation. The typical presentation in sports is an athlete complaining of pain on top of the foot after a forefoot twist, loading injury, or a fall. Patients may have felt or heard a pop. Edema and ecchymosis may be present, especially with fracture. Compartment syndrome can occur with severe injuries and should be addressed acutely. Subtle Lisfrances injuries such as milder sprains may have minimal edema and no ecchymosis. Provocative maneuvers include frontal plane stress of the metatarsals against the tarsals, or between the midfoot bones. A good test for Lisfrances ligament involvement is moving the first and second metatarsals in opposite directions to provoke pain. Figure. This is indicative of Lisfrances injury. Weight-bearing, unshod, examination for symmetry especially of arch height is performed if possible. If pain and edema does not allow for comparison weight-bearing examination and X-rays, patients should have careful inspection of their non-weight-bearing films. If fracture or dislocation is suspected, a CT should be performed. Figures. Preoperative weight-bearing antero-posterior, AP, X-ray showing widening. This is indicative of Lisfrances injury. Weight-bearing, unshod, examination for symmetry especially of arch height is performed if possible. If pain and edema does not allow for comparison weight-bearing examination and X-rays, patients should have careful inspection of their non-weight-bearing films. If fracture or dislocation is suspected, a CT should be performed. Figures. Preoperative CT. Treatment. Lisfranc and midfoot sprains can be treated non-surgically when the corresponding articulations are not disrupted more than 2 mm with weight-bearing images 0.1 to 5 if there is widening of more than 4 mm of Lisfranc's ligament or offset of 2 mm or more. Surgery should be considered. Figure. Stabilization is achieved, often with screw fixation. With severely comminuted intra-articular injuries, primary arthrodesis, particularly in the medial 3 Lisfranc's articulations, can be considered. Preoperative weight-bearing antero-posterior (AP) X-ray showing widening. Stabilization is achieved, often with screw fixation. With severely comminuted intra-articular injuries, primary arthrodesis, particularly in the medial 3 Lisfranc's articulations, can be considered. Bioabsorbable screws can be utilized for open reduction internal fixation (ORIF), as they may decrease the need for hardware removal at a later date. Figure. Postoperative weight-bearing antero-posterior X-ray. In chronic cases where arthrodesis is not preferred, such as in athletes, soft fusion with bioabsorbable or metallic screws may be needed. An incision to expose the first and second tarso-metatarsal articulations may be needed to remove fibrotic tissue so that realignment can be achieved. As with any surgery in this region, great care should be taken to avoid traumatizing the neurovascular structures. Newer fixation options exist for stabilization of Lisfranc's ligament, including suture button techniques such as a tightrope or tightrope FT, Arthrex Inc., Naples, Florida, United States of America. Figure. Primary fusion can be active with screws and/or plates. Displaced avulsion fragments of show parts region, such as dorsal talonavicular and the anterior calcaneal process, can be excised or fixated as needed. Tightrope fixation for Lisfranc's: A. Image-guided tapping. B. Placement with suture button being tied. C. Image confirmation of reduction. Author's preferred surgical technique. Generally, ORIF is performed within the first 2 weeks after injury. Confirmation of dislocated joints and intra-articular fractures is generally performed preoperatively, though with patients who have suspected Lisfranc's diastasis and questionable widening, stress view under anesthesia can be done. Patients with isolated Lisfranc's injury can often have the procedure performed without tourniquet, percutaneously. Neurovascular structures are identified. Lisfranc ligaments. 1. C1 equals medial cuneiform, M2 equals second metatarsal base, M3 equals third metatarsal base, red equals dorsal Lisfranc ligament, blue equals interosseous Lisfranc ligament, green equals plantar Lisfranc ligament. A large, pelvic, reduction forceps is placed after manual reduction with the tips on the medial cuneiform and lateral second or even third metatarsal base. Imaging can be used to help guide placement of an approximately 2.6 mm drill, which will course from the medial cuneiform and exit the lateral aspect of the second metatarsal base. One should avoid drilling into the first metatarsal cuneiform joint for placement of this particular fixation. In cases with isolated Lisfranc's injury in this region, a tightrope FT can be utilized. After proper placement, the foot is stressed to see if it is stable and secure. If widening still occurs, a 3.5 to 4.5 mm bioresorbable or metallic screw can be placed more proximally. Figure. It is critical to stress the patient, on the table, to ensure that fixation sufficiently stabilizes the dislocation and instability is reduced. Additional screw fixation for Lisfranc injury. In cases where there is also first or second tarsometatarsal disruption, the clamp and drill bit are maintained in place. However, stabilization screws for these joints are placed first from distal to proximal, then the final, Lisfranc's, fixation is placed. In situations where there is significant comminution of the medial aspect of the second metatarsal base, the Lisfranc's fixation can be placed from the second or even third metatarsal base proximally into the first cuneiform. In situations where the first tarso-metatarsal joint is disrupted, diastasis should be reduced first. However, when using a tightrope FT, the temporary drill bit can be left in place until other screw fixation is performed elsewhere, so that the suture does not inadvertently get drilled out. If displaced as well, intercuneiform and naviculo-cuneiform screws should be placed as needed. Typical postoperative care is cast, boot immobilization for 4 to 6 weeks. Generally, partial weight-bearing is allowed after 4 weeks if weight-bearing X-rays show good alignment and reduction. The midfoot is not mobilized in physical therapy, which typically begins around 8 weeks. Patients often wear a walking boot until 8 to 12 weeks postoperative. Return to sports typically takes more than 4 months, and athletes who sustain these injuries in season will miss at least one season, as full return can take 1 year. Chronic cases both with and without prior surgery may still necessitate arthrodesis, which has not been well studied in the athletic population. Anecdotally, the author has performed midfoot fusions both in the acute and chronic setting on patients who have been able to do some running and jumping sports. Discussion: Lisfranc and midfoot sprains often result in a loss of one sports session. Average return to sports for sprains is 4 or more months. One study on athletes showed that a delay in diagnosis and treatment of more than 6 weeks resulted in statistically decreased likelihood of full return to activity. Arthrosis can still occur despite anatomic reduction. Follow-up with arch supports or inserts is often recommended. Chronic instability and pain after these injuries may require arthrodesis of the affected joints. Patients with Lisfranc and midfoot injuries should be counseled on the potential debilitation and rehabilitation involved with their injury. Thanks for watching. Please subscribe my channel. Thanks for watching. Please subscribe my channel. Kamal Gokis MD. Bascent University Alanya Research and Practice Center. Orthopedics and Trauma in YouTube. Subscribe.